Hello everyone and welcome. My name is Sammiya Chaudhry, a DNP FNP student at Maryville University. Today I am honored to present my scholarly project titled Improving Nurse Adherence to Skin Assessment Protocols to Reduce Sacral Pressure Injury Rates, specifically focusing in the medical intensive care unit. Thank you for taking the time to join me today. I'd like to take a moment to acknowledge and thank my committee, Dr. Jessica Bland, Chair, Dr. Maria Snell, Second Reader, and Molly Harper, who was my community partner and MICU nurse manager. Their guidance and support have been crucial throughout this project, and I'm truly thankful for this team. A little bit about the background and significance of this project. Pressure injuries remain one of the most persistent and preventable patient safety issues in the medical intensive care unit. Critically ill patients experience prolonged immobility, sedation, and hemodynamic instability, all of which increase their risk for skin breakdown, especially over the sacrum area and other areas with sensitivity. But the focus of this project is on the sacrum area. In our MICU, a review of unit-specific data revealed that sacral pressure injury rates were higher than expected benchmarks and higher than other units in the hospital. Staff adherence to skin assessment protocols also varied significantly, and these preventable injuries do cause pain, infection risks, longer hospital stays, and increased healthcare costs. All factors that do make this a priority for a quality improvement. For the review of literature demonstrates that pressure injuries are common in critical care settings, with some studies show reporting up to rates 50% or higher, especially in high-risk populations. Research strongly supports that structured skin assessments and the use of tools like the Braden Scale Score to identify risks early do make a difference. Evidence also shows that silicone-based foam dressings like the Mepilex significantly decrease skin breakdown and are most cost-effective comparing it to treating an injury once it's actually developed. However, studies significantly show that nurse adherence to protocols is the primary barrier in preventing these pressure injuries. However, workload demands, documentation fatigue, and inconsistency in workflows can all contribute to causing this MICU risk. The literature made it very clear that knowledge is not enough. Adherence to protocols is the key determinant of the outcomes for the patient themselves and the hospital setting. So my project was guided by Kolkaba's comfort theory, which focuses on holistic comfort through relief, ease, and enhanced healing conditions. By improving how consistently we assess and protect our patient's skin, we promote physical comfort while preventing additional harm to them. This theory reinforced the purpose of this intervention, which was to improve safety, dignity, and patient experience. This was a quantitative pre- and post-intervention quality improvement project. The intervention included staff education in the medical intensive care unit of a specific hospital in Tulsa, Oklahoma, reinforcement of the 4 eyes in 4 hours protocol, which was already taking place at that specific hospital. The 4 eyes in 4 hours protocol is when we receive a patient in the NICU. Within the first 4 hours, 2 nurses are laying eyes on the patient. So there's 4 eyes on the patient within the first 4 hours of them arriving to the unit and the first 4 hours of starting a shift. This was already in place at that hospital, but it just wasn't being reinforced. So that was one of the methods as well, interventions for this project. We also focused on emphasis on Braden scale scoring accuracy, making sure our nurses are accurately putting in the data in the EMR and scoring correctly. And routine preventative Mepilex dressing use, that we are applying the Mepilex dressing as nurses to patients that arrive on the unit, and then at the start of shift and when handing patient over to another nurse, making sure that there is a Mepilex on that sacrum on all high-risk patients. We also did weekly audits and performance feedback for the methods of this project. Why did we choose this design? This structure enabled us to directly compare outcomes before and after education and to measure whether protocol adherence did truly improve. So our sample size was a total of 154 medical ICU patients who were hospitalized for at least a minimum of 24 hours and were identified as high risks for skin breakdown. So they had to be scoring above an 18 or below an 18, on the Braden scale score for them to qualify as being part of the sample. 77 of the patients were in the pre-intervention, and we had 78 patients in the post-intervention. Staff that was being educated was nurses and nurse aides. Because they were the only ones applying the intervention, this made it a fully nurse-driven safety initiative protocol. And patients ranged in ages from 18 to 98. Like I mentioned, they were high acuity, immobile, and low Braden scale scores. They had to meet these qualifications to be a part of the sample. Data was securely entered into Excel and analyzed in the SPSS for the statistical analysis. We used patient data collection forms, which we obtained from the nurses, and then we added that to the Excel, and then it was analyzed. We examined changes in Braden scale documentation, skin assessment completion, Mepilex application, and incidence of sacral pressure injuries. These were kind of the data collection points that we focused on. A lower tail z-tests for differences between 2 proportions was used. Because our hypothesis was directional, we expected pressure injury rates to decrease. We used a standard significance level of a p less than 0.05. So this slide kind of summarizes the project workflow and timeline. I began planning in mid-June by developing the patient data collection forms, which were blue forms that were handed out to the nurses to collect information specifically focusing on patient age, the Braden scale score, and if there was already a pressure injury present prior to admission versus not. During this time, I also collaborated and coordinated with the MICU team and leadership. Kind of had a discussion with them on how the flow of this project will go. Next, I did obtain approval from IRB in the facility itself. These were both obtained by mid-July, allowing me to move forward with the project. After the approval, I met with the data analysis and educated the nursing staff on the updated skin assessment procedures that were implemented in the unit already, so that everyone was prepared before implementation actually began. Data collection occurred from July 16th through August 20th, which included both pre and post-intervention phases. During this period, the EMR data and pressure injury outcomes were closely monitored. And finally, data was analyzed in late August to confirm the accuracy and to determine the impact of the intervention. So the results were significantly powerful. Before the intervention, 23.1% of the included patients developed a sacral pressure injury. After the intervention, that number dropped to 10.4%. Statistically, this was very significant. The Z equaled negative 2.1137, and the p-value being 0.0173, which was less than that p-value we were initially aiming for, being 0.05. Meaning that the improvements were not just due by chance, they were actually due to the implementation of this project. We also saw a clear increase in documentation accuracy and the consistency with preventative dressing use. So overall, in short, this intervention did work. It reduced patient harm in a meaningful way. As you can see on this chart, I had separated the pre in red and the post in blue, and you can see that drop very significantly over that short period of time that we did implement the project. With the results being so significant, we also did have some limitations, several factors that may have influenced the outcomes. One, it being done in a single site. We focused on just one NICU in the hospital, which is about a 30 unit bed NICU. That can be limitation due to the generability and comparing it to other settings with different staff or different patient populations. We also did have a short evaluation period, which didn't allow measurement of long-term sustainability. From it being from July to August, it was about a 4-week implementation period, which isn't very long-term, so we can't determine the long-term sustainability of the project with it being such a short time frame. Variations in documentation could have also occurred during the period, especially during high acuity times. Sometimes the nurses did get busy with codes or very ill patients that they didn't have time to initiate that 4 eyes in 4 hours, or they just didn't have the resources to have enough staff to come in and lay eyes within the first 4 hours. So that could have impacted some of the documentation and data. I did implementate this project during summer time, which could have also influenced some of the results, especially with staffing changes and shortage in some of the supplies. We did have a short period of time where temporarily Meplexes were out in supply, so we did have a period of time that was challenging during this. Staff awareness and audits may have temporarily boosted the performance. Even with limitations, our data did show patient safety outcomes did improve significantly, which strengthened the confidence in this intervention. So this project aligns perfectly with published evidence. When nurses are supported, educated, and provided with clear processes, it shows that patient outcomes do improve. Improving adherence to simple but high-value tasks can prevent life-altering harm. This demonstrates that the critical role of nursing, being consistent with these protocols and being adherent to these protocols in critical care settings are very effective. Most importantly, nurses expressed more confidence in preventing pressure injuries after receiving the education I was providing and the ongoing feedback. A lot of them did report back to me that they felt that the educational reminders did impact their performance, and they were focusing more on the skin, especially in those areas that are more sensitive, like the sacrum. This project empowered not only the nurses, but I think the empowerment is what drives a lasting cultural change within the unit itself, and then hopefully expand not only in the unit, but in the hospital overall and in the healthcare environment. The results reinforce that prevention is not only better than treatment, it is safer and more cost-effective. Reducing avoidable injuries has a positive impact on patient comfort. It shows fewer infections and complications. It shows shorter hospital stays, better alignment with safety benchmarks for the hospital and for healthcare environments overall, and cost saving that can exceed tens of thousands of dollars per individual and case. This project provides a strong foundation for sustaining and expanding these protocols hospital-wide. So we incorporated ongoing education, EMR reminders, and quarterly audits from the MICU manager, but it showed improvement in all these significant things like patient safety, overall nursing confidence, organizational cost savings, and quality metric performance overall for the hospital and for the medical intensive care unit itself. So in conclusion, sacral pressure injuries were reduced more than half, comparing it to the pre-intervention. We saw a cut down in the sacral pressure injuries, whether them being a stage 1 all the way to stage 4, it was cut in half by more than half of the patients. That included doing the 4 eyes and 4 hours assessments protocol and applying the MEPLEXs in time, making sure each high-risk patient is documented correctly in the EMR, and we are, as nurses, physically going in and assessing the skin and applying these MEPLEXs, making sure that we're a part of the prevention for patient safety. It also, nursing compliance did improve across multiple prevention measures. They were documenting on time. They were more focused on skin. I know it's sometimes hard to focus on skin, especially being in such a high acuity area with critical care patients. These things are small, but sometimes they can be life-threatening for our patients. So I think that nurses were able to kind of acknowledge that, and they were reminded of that importance. It showed leadership support and availability of supplies that remain critical for sustainability and continued monitoring. This project not only strengthened my skills in leading nursing practice changes, using data to drive decisions, and advocating for vulnerable intensive care unit patients. As a DNP prepared nurse practitioner, I will hope to continue promoting evidence-based strategies that protect patients from preventable harm, especially those who cannot advocate for themselves. And I think this DNP project really did make a difference, not only in the medical intensive care unit it was taking place, but based off this data, I hope that you guys were able to take away how important it is that nursing initiative and how much we can make a difference being in the healthcare field as well. I want to thank you all for your attention. I appreciate you guys listening in. I hope you guys were able to learn something from my scholarly project. And I do welcome any questions. If you guys would like to email me, you could send me a short email. I'm willing to answer any questions. Thanks for listening. Bye-bye.